Hello and good day. I bid to Professor Dr. Zainal. My name is BETTNEY JAMACHIA, and in this video I'm going to present about ophthalmology, which mostly focus on pediatric ophthalmology, a medical specialty regarding the eye that I'm interested in. In this presentation, I'm going to cover about the anatomy and the physiology of the eye, as well as the biochemistry of the eye, in which how do we see vision, and I'm going to talk about eye disease as well as its treatment and a well-known specialist that I admire. As you can see here, this is a picture of an eyeball. The wall of the eyeball consists of 3 layers. Starting from the superficial layer of the eye, or sometimes it can be referred as the protective layer, it consists of the sclera and cornea. The sclera is the white part of our eye, which is to protect the internal structures of the eye and provide stable base for retina, while cornea is a transparent avascular tissue that is responsible for structural barrier of the eye and to protect eye against infection. For the middle layer, it is a layer that is vascular for nutrient supply. It consists of choroid, iris, and ciliary body. Together, they are named uvea. The choroid function is to supply blood to the eye, as well as to provide oxygen and nourishment to the outer retina. It consists of 5 layers. As for the iris, it is the colored part of the eye. Its main function is to control the amount of light entering the eye by adjusting the size of pupil, and it consists of 2 sheets of smooth muscles, which are the sphincter muscle, which is responsible for constriction of the pupil, and dilator muscle, which is responsible for dilation of the pupil. And it also consists of ciliary body for the middle layer of the eye, and its function is to produce aqueous humor and change the shape, as well as hold the lens through the ciliary muscle. For the deep layer of the eye, it consists of retina. It detects lights and converts it to electrical impulse to send to the brain for visual recognition. It has 2 types of photoreceptors, which are cones and rods. For rods, it is responsible for low light vision and are not able to detect colors. For our cones, it is responsible for bright light vision and are able to detect colors. There are 3 types of cones, which are named after the color they absorb best, which are red, green, and blue. For the anterior part of the eye, there are pupil, lens, and aqueous humor. The pupil allows and regulates the flow of light to the retina, and the lens helps to focus light on the retina by bending or refracting it to create a clear image. The aqueous humor keeps the eye inflated and provides nourishment. As for the posterior part of the eye, there is a vitreous humor, which is a fluid inside the eyeball that's separated from aqueous humor by the lens. Its main function is to maintain shape of the eyeball. It also has optic disc, which is the part where optic nerve leaves the eye, as well as part where retinal arteries and retinal veins pass through. The optic nerve can also be found on the posterior part of the eye. Its function is to transfer visual information in electrical impulse from retina to the visual cortex of the brain. It is made of ganglion cells. Generally, the light travels from the cornea to the pupil to the lens and lastly to the retina. It involves the bending and refracting of the light on the lens depending on the intensity of light. Ciliary muscle will either contract or relax to adjust the shape of the lens. Pupil will also constrict or dilate with the help of sphincter muscle or dilator muscle depending on the intensity of the light. As the light hits the photoreceptor in retina, it activated the action potential. Stimulus will be sent from the photoreceptor to bipolar cell, and from bipolar cell to ganglion cell in electrical impulse via the optic nerve to the visual cortex of the brain to be interpreted. Here, I'm going to use rod cell to explain the action potential through phototransduction. Phototransduction is a process where light energy is converted into electrical impulse in the retina. This process is pretty similar with the cone cell. To be clear, the visual pigment in rod cell is rhodopsin, while iodopsin for cone cell. Rhodopsin is made up of opsin, which is an inactivated form of rhodopsin, and retinal, the one who will absorb the light. Photoreceptor will remain in the polarized state due to the influx of sodium ion flow into the photoreceptor through the ion channel, which is activated by cGMP. This will cause the continuous release of glutamate. When the rod cell absorbs light, the opsin is activated. It then will change to transducin and activate the phosphodiesterase. The phosphodiesterase will break down the cGMP, which will cause the closing of ion channel. And it also causes the hyperpolarization of cell due to the continuous efflux of potassium ion. This will cause the release of glutamate to decrease, which then will give signal that light stimulus is present. Rod cell then returns to its normal state quickly after the activated rhodopsin is inactivated. Aroustin will bind to rhodopsin, which will inactivate opsin. Therefore, opsin cannot form transducin. This restores the retinal to its original configuration to be ready to absorb light again. Next, I'm going to talk about a disease regarding the eye in children, which is the cataract. It is normally rare to occur in children. Cataract is an ocular condition in which the lens of the eye is becoming opaque or cloudy. The opacity prevents lights from traveling to the lens properly, and it can be unilateral or bilateral, which means it can affect either one eye or both of the eyes. Congenital cataract is a type of cataract that presents since birth. Pediatric cataract is the leading cause of pediatric blindness. Some of the causes of cataract in children are genetic abnormality, trauma during childbirth due to the penetrating or blunt injuries to the eye, and premature birth, as well as secondary causes such as ocular inflammatory disease, infections, and metabolic disorders, as well as iatrogenic, which is due to the laser therapy or radiation. The complications with children with cataract is amblyopia, which sometimes people refer to it as lazy eye, in which it affects the ability to see clearly out of both eyes. And it is common in unilateral. One of the diagnoses that can be made is by doing the red reflex test, which is done at every visit for newborn. The treatments for cataract in children can be either non-surgical or surgical. For non-surgical, this treatment is done if the cataract is less than 3 millimeters or not very dense. It is done by using a part-time patching on the eye to prevent amblyopia. Patching helps better focus because it forces the brain to favor the weaker eye, and it must be monitored regularly for progression. As for the surgical treatment, it is done if the cataract is more than 3 millimeters or is very dense, and the surgery must be done by 16 weeks of age. For unilateral cataract, the surgery must be done by 6 weeks of age, while on the other hand, the bilateral cataract must be done by 8 weeks of age with 1 to 2 weeks gaps for the second eye. It involves lancectomy, capsulectomy, and vitrectomy, and instruments used are the forceps, scissors, and intraocular lens. So this is the procedure for the surgical treatment is as follows. First, the surgery on the patient with cataract will be done under general anesthesia. Patient will be given eye drop to dilate the pupil. A small incision is made using the scissor on the cornea to allow for the cloudy lens to be removed using the forceps. Intraocular lens will replace the removed lens to restore the ability of the eye to focus. The eye cannot focus if there is no lens. A well-known specialist that I admire is Frank D. Kostenbeder. I admire him because he understand he tried to understand children who were ignored and often considered as a disruption to the normal office routine of an adult practice. His passion in the ophthalmology is what makes me want to pursue this medical specialty in the future. That is all from me. Thank you.